time out of your schedule. So today we're going to be talking about growth hormone and secretagogues. I've been using growth hormone secretagogues since the mid-90s and used to use quite a bit of growth hormone throughout the courses because of all the benefits of growth hormone. And I'm going to start by basically justifying with the science and literature that's out there why growth hormone is an incredible beneficial hormone to replace in the body regardless of the age. And we'll talk about some of the risk factors that are mythology, just like testosterone and prostate cancer. Growth hormone does not increase cancer, and as you'll see from what I'll present, it actually decreases it through a nuclear mechanism with p53 that we'll talk about in detail. So these are some of the topics that we will be addressing. I don't have to read them off because I think everybody gets a copy of this. But the introduction to why replace growth hormone, I can spend the full day talking about the benefits, but we don't have a full day, and I don't think you'd want to listen to my voice for more than a couple of minutes anyway. So the areas that we're going to talk about are neuroendocrinology, action of growth hormone and IGF-1, laboratory diagnoses of deficiency, growth hormone activation of IGF-1, cancer and growth hormone, treatment options, secretagogue technology, and then finish with the combination that we've been using of growth hormone and secretagogue to get a better response than either of them by themselves. And we'll start off with this case, and I'll just ask you to look at it. We'll address it at the end if we have time. But looking at growth hormone, 14.2, the median is 5. Remember, growth hormone only has a half-life of 20 minutes, unbound 30 minutes bound to its carrier protein. IGF-1 has an 8 to 10 minute, and the median is about 467, and binding protein 3, median's about 5,000 and has a 20 to 24 hour half-life, and this is at 7,200. So obviously there's something causing the growth hormone in natural state for it to be elevated, and we'll talk about that at the end. It's the main issue of what I do in what I do. So the question is, why replenish growth hormone? And this is the growth hormone dilemma that we have every time we see a patient. Should I or shouldn't I? Some of the reasons for not touching growth hormone is because of the legal aspects to it, which I won't get into great depth other than to say in most states out there, aside from California, you have to do a challenge test. California, you don't have to do a challenge test due to Dr. Edmund Chen, who went up against the Medical Board of California and won, finding that they should not isolate growth hormone as a special hormone. It's just like thyroid, growth hormone. If you and your clinical acumen feel that the patient would benefit from growth hormone here in the state of California, we just use it. Yes, we do have to show IGF-1 and maybe growth hormone deficiencies or history of head trauma is the key here. So under neuropsychiatry, in this study, what they found is that people had resistance to treatment for depression, also called atypical depression, that 61% of the people have growth hormone deficiency. And within 1 to 2 months of replenishing growth hormone, their symptoms of depression disappeared. They also ended up with 4 benefits. And the benefits were improvement in emotional reactive score, which means that they were not as reactive to stressors around them. Social isolation, which is also part of depression. They became more gregarious, more interactive with people, as opposed to having a higher level of social, lack of social interaction, therefore social isolation. Their mental energy increased significantly, and their sleep disturbance improved immensely, okay? So that is on the neuropsychological aspect. And in this article here, came out in 2010, growth hormone deficiency patients are depressed and have cognitive impairment. And it turns out that growth hormone, as you'll see in this presentation, has an incredible effect on helping neurons regenerate. In studies done in Alzheimer's disease, the microtubules that are destroyed because of tau protein problems can regenerate the microtubules so acetylcholine can go through them. And that's the reason why we use poor drugs like Aricept and Memantine to increase ACH by blocking the acetylcholinesterase or inhibiting acetylcholine. You don't need to do that. Growth hormone will increase that, as well as thyroid, as well as testosterone, which we'll talk about in another session. So cardiology, they found that growth hormone deficiency, with growth hormone deficiency, there are 9 markers of cardiovascular risk that go up, and some of them are listed here, and that you can actually get improvement in the hardening of the arteries, in the elasticity of the endothelium with growth hormone. And they believe it has something to do with not only repairing the damage. In the process of atherosclerosis, you have damage to the endothelium, and the body tries to fix it. If it can't fix it, it laminates it with calcium. And it's the calcium that causes atherosclerotic plaque. It's not cholesterol, it's the calcium. So what happens is growth hormone helps to fix that and returns elasticity. In the cardiovascular literature, it talks very specifically about the elasticity of it. Also, growth hormone helps with nitric oxide synthetase. So what it does is it helps with the vasodilation of the arteries. You remove the stiffness of it, rigidity or stiffness, and you also improve the nitric oxide synthetase or endothelial nitric oxide synthetase to increase nitric oxide production. In addition, it downregulates the cause for hardening of the arteries, which is the interleukin-6 and tumor necrosis factor alpha. That's what causes the damage to the lining of the arteries, such that calcium laminates it. Homocysteine, we talk about homocysteine. Well, homocysteine is generated from failed protein synthesis. If you remember back in, in our cellular metabolism, the initiating amino acid of any protein syntheses is methionine. And if you have interrupted protein synthesis, a lot of broken chains or peptides with methionine at the head are released into the circulation, and the body converts the methionine into homocysteine. So why is that happening? The reason why it's happening is because growth hormone's product, IGF-1, is what helps to regulate ribosomal functioning. With ribosomal deficiency, you end up having more homocysteine because you have interruption of the 40-60 subunits.
Dr. Gordon, can you unmute yourself again?
Me, you did. Okay.
Sorry.
Okay, so let me reiterate. So in this study on Crohn's disease, growth hormone helps to downregulate the inflammation. And it's the inflammation that causes problems with digestion, leaky gut, and inflammatory gut diseases. It turns out that growth hormone is a cytokine modulator. It's in a classification called class 1 cytokine. A growth hormone is considered a cytokine. So it modulates our immune system, as well as a couple other areas that I think I have a slide on. Pulmonology, with children with cystic fibrosis, they found children who were deficient, who had cystic fibrosis, had inherently a deficiency of growth hormone. And when they replenished the growth hormone to the average level of that age of the child, they weren't going to hospitals as much. And they weren't, they were growing, because in these children with cystic fibrosis, the inflammatory cytokines get into the brain and interrupt the neurosteroid production in the brain. That's what I do with all the military that I work with blast trauma, is that these inflammatory cytokines disrupt the entire chemistry of the brain, and they don't get the reparative benefits of growth hormone. But in cystic fibrosis, they don't get the infections, they don't have the hospitalizations. If they are hospitalized, they get out of the hospital a lot faster. Under immunology, growth hormone influences the immune system by interferon, gamma interferon, type 2 interferon. Innate and adaptive immunity is enhanced, so it can fight against viral attacks as well as bacterial attacks. And we'll talk about the tumor control a little bit later. So growth hormone in the immune system, orthopedics. Adults with growth hormone deficiency have a significant reduction in the cortical bone. So they're more at risk to fracturing. And in this study, when they looked at the use of bisphosphonates, these here, they found that in 10 years, there was a 23% improvement. Growth hormone improves the bone density by 1.6 every 6 months. So if you take it linearly, it's about 3.2 for a year and about 32% in 10 years without the side effects that these drugs have on osteonecrosis. So increases BMD, bone mineral density, and in 10 years, fractures decreased from 56 to 28% in patients who were given growth hormone. In the control group that did not get the growth hormone, it increased from 8% to 32%. So a significant improvement on growth hormone and a significant worsening when they weren't on growth hormone. Vitamin D, the process of vitamin D, skin, liver, kidneys, and so forth. The growth hormone, healthy levels of growth hormone helps the kidneys in making activated 125 cholecalciferol, dihydroxycholecalciferol. So it helps with calcium metabolism. Endocrine, interesting that when you do use this, you can take as a positive, negative kind of thing. If you use growth hormone, it will accelerate the conversion of T4 to T3. So what happens is T4 levels drop and T3 levels go up, and the T3 levels being up shuts down TSH. So what can happen is it can unmask a central hypothyroidism if the TSH doesn't go up, okay? So by using growth hormone in a person who doesn't have this central unmasking issue, you'll see a natural conversion, rapid conversion of T4 to T3. So you'll look at the T4 and think you need to add, tetraiodothyronine. You don't. Understanding that this is the pattern that you get when you put people on certain hormones or certain medications is important. And that's the bottom line on this, to know that it causes that conversion. Now, in the rapid conversion of T4 to T3, what can happen in some people is the T4 goes to reverse T3. In people with selenium, iodine, B6, B12, ferritin, iron, and elevation in cortisol can rapidly cause the T4 to convert to reverse T3 as opposed to keeping T3 levels. Oop, I don't know how that happened. I'm still there. Let's close that. Okay. In patients who have weight issues, okay, like this gentleman was 396 pounds. At the end of 9 months, he was 229 pounds. What happened with Chris is that he had a selective growth hormone deficiency because of obesity. Obesity feeds back to the brain either through ghrelin or leptin or one of those, and shuts off the ability of the pituitary or the hypothalamus to release growth hormone releasing hormone to the pituitary to release growth hormone. And what happens is you start accumulating body fat. So one, obesity shuts down, blunts your production of growth hormone. And two, growth hormone has an incredible ability to mobilize structural fat, which is called non-esterified free fatty acid, NEFA. So in studies done where people had low growth hormone at bedtime, at night, because growth hormone is produced 8 at night to 4 in the morning, that they had a greater tendency of accumulating central obesity. His arms were relatively thin as well as his legs. Everything was in the abdomen, similar to what happens with elevation of insulin level in insulin-resistant type 2 diabetes, because it's the hormone of storage. Don't forget that growth hormone stimulates IGF-1, which has a 10% crossover to insulin, so it will cause you to store more sugar than having low levels. And this is the blunting article. And high levels of growth hormone, the reason why we should not be using high levels, but small levels. What happens is growth hormone has an incredible benefit of lipolysis. So it'll strip the body fat, and that elevation in body fat, triglycerides, will blunt or block the unique growth hormone receptors. Growth hormone receptors, just like prolactin, have a dual receptor. So what happens with high levels of fat, it can block one of the receptors, so the growth hormone's effect on cellular mechanisms or metabolism is lost, and you don't get the benefits. So what we'd like to do is use lower levels of growth hormone to increase the IGF-1 that counters the growth hormone. So it's always a balance in our body. Nothing is free. It's always keeping this balance. So there are doctors outside the United States that use a lot of IGF-1 because of the benefit on mobilization of sugar, as well as you don't have the blunting effect of growth hormone, or in combination using growth hormone and IGF-1 to get the maximum benefits of GH, which you'll see shortly, and the benefits of IGF-1. In cancer, well, we know growth hormone does not cause cancer. In this study called the Melbourne Collaborative Study, 41,000 people, they looked at IGF binding protein 3. What's in the literature, if you look, is there are thousands of articles talking about the protective aspect of IGF binding protein 3. Remember, binding protein 3 is the main carrier of IGF-1. So if there's a good quantity of IGF-1, it carries the IGF-1, which removes it from the mitotic pool that we'll discuss when we get specifically to the cancer. But they found that a small elevation in binding protein 3 leads to a 48% reduction in colon cancer. When I looked at the mechanism in the intranuclear, the nuclear genetic mechanism with P53, P21, and P23, it turns out it applies to all forms of cancer. Okay, this is a study on 300 women. They looked at IGF-1, binding protein 3, and binding protein 1, and they found no association with breast cancer and in premenopausal women and these levels. They actually found in other studies where binding protein 3 helped prostate cancer and breast cancer. Neurology, growth hormone enhances neuroregeneration and improves microtubules, as I talked about previously, and helps to reestablish a neuropermissive growth environment, an environment which fosters repair of neurons. IGF-2, we don't talk very much about IGF-2, but it is produced. During gestation, it's produced almost uniquely, primarily solo in the brain because of how it functions to stimulate neuron growth and repair in neonates. And we're starting to find levels in adults. Who has it? Healthy individuals, physically fit, exercising, great levels of hormones. This is about the importance of having good level of estrogen. I throw this in for docs who tend to use the anastrozole when they're using testosterone. You don't need anastrozole to block estradiol because estradiol has so many benefits. That's in the testosterone estrogen lecture, but it has so many benefits. You know, it increases growth hormone production in the brain. Growth hormone and estradiol in the liver increases the 9 proteins that are produced under the direction of the growth hormone. I'll show them to you shortly. It increases nitric oxide synthetase in the brain, so vasodilatation, protects the lining of the arteries, protects the bones, protects the heart, increases libido. Some of the basic things. And the other thing that it does is neuroplasticity. Look at all the studies with women who have had strokes or develop dementia. Women with healthy levels develop it slower, or they don't develop it because of the protective nature of not only estradiol. I don't want to weigh heavily on estradiol, but it's all the hormones, all the neurosteroids that we address in blast patients or in our head trauma patients. The neuroplasticity is regulated in Alzheimer's by the fact that all these hormones, testosterone, estradiol, estrone, estriol, pregnenolone, allopregnenolone, pregnenolodiol, all these things help a transport mechanism called neprilysin to remove beta amyloid. But where does beta amyloid come from? It comes from the breakdown of the microtubules, the tau proteins, the tubulin A and B, and the tau proteins, the fibrils. You can stop that by controlling the inflammation, as well as helping to regenerate the microtubules with growth hormone. Oligodendrocytes are damaged with tumor necrosis factor alpha. IGF-1 decreases tumor necrosis factor alpha and enhances induced enhanced apoptosis. That should really read and enhances apoptosis. Tumor necrosis factor alpha leads to death of cells. Activation of caspase-3, which is an incredible mechanism, the caspase system, which is called the messengers of death. In fact, caspase-3, once you initiate this apoptosis, the cells die. In healthy neurons or in neurons that are exposed to challenge, if you don't have good levels of IGF-1, they die, and they kill oligodendrocytes that produce myelin. And you can increase myelin production with DHEA. Okay, neuroendocrinology, regulation of growth hormone, the boring science. Well, the hypothalamus has a censoring system where it meters all the hormone levels in our body. And if the levels are low, it sends a signal, unique signals that exist, to the pituitary to tell it to release whatever. So in the hypothalamus, the growth hormone releasing factor goes and tells the pituitary to release growth hormone, and it releases growth hormone. And the mechanism of feedback, which is something important for use of any kind of secretagogue or injectable growth hormone, when you use either of these, you have to monitor the fact that at some point, the level of growth hormone that you've rekindled or generated or induced by giving it will cause the natural mechanisms, somatostatin, SS, to shut off the somatotropes in the pituitary, as well as shut down the sensor in the hypothalamus so it doesn't release growth hormone releasing factor. You need to keep those in clear sight, because ignoring them will give you a hard time of understanding how to optimally use growth hormone and or the secretagogue of choice. So looking at the paraventricular nucleus, this is more to talk about with traumas that involve rotational force, car accidents, slip and fall, and other forms of injury. Paraventricular nucleus makes somatostatin. Let me back up a second. In this area, this is the third ventricle area right here. So paraventricular nucleus shuts down growth hormone. The arcuate nucleus increases growth hormone releasing hormone to have the pituitary release it. And then the supraoptic nucleus produces the ADH and oxytocin. And in head trauma, we don't see very many cases of posterior pituitary problems. We see mostly anterior because of where it's located. Okay. So as we mature, there's a 14% decrease in growth hormone production per 20 years. Now, I personally believe that the reason why we see this extreme curve is because throughout life, we're accumulating traumas, birth trauma, 5 years of age riding a bike, or 3 years of age riding a bike, roller skating, skateboarding, car accidents at 16, getting into a car. And in what I see in our patient population, and I do mostly neuroendocrinology now, is that the accumulation of small traumas leads to a major decrease in the hormones. And if you do the appropriate laboratory testing, the complete laboratory testing, you'll see the pattern. If you just do growth hormone level, you won't see the pattern. If you just do IGF-1, you won't see the pattern. If you just do binding protein 3, you won't see the pattern. You need to do all three of them so you can define why the person, or else take a great history that includes looking focally at traumas. And you don't need to be knocked unconscious. This is the fight I have with the Department of Defense, is that you can have either 10 dimes or $1. They're both 100. You can have 10 small injuries without loss of consciousness, without headache, without anything, but it can accumulate over time. Okay, so looking at production of growth hormone in youthfulness, remember from 8 at night until 4 in the morning is the peak of growth hormone production. And in younger folk, this is how it's produced. And as we get older, it blunts. Is that the accumulation of damage to the hypothalamus and pituitary? Is it changes in our nutrition, physical functions, gut absorption? It needs to be assessed. So what are things that will stimulate the production of growth hormone? Growth hormone releasing hormone from the arcuate nucleus, ghrelin, which is produced in the gut. Ghrelin is interesting. If you eat a good protein meal that has the alpha-ketoglutamine, glutamate, arginine, and so forth, it'll stimulate ghrelin production, and ghrelin increases growth hormone releasing hormone. Sleep, melatonin will increase the production of growth hormone. Dopamine, specifically the DR2 receptors or the D2R receptors, which is stimulated by using things like Wellbutrin, amantadine, an antidepressive medication, amantadine hydrochloride, which is used for influenza, or using mucinapurins, which is a natural product that gives you dopamine. So in patients who are with Parkinson's on the traditional medication, you'll see this incredibly high level of growth hormone. All you need to do is add to it DHEA and testosterone and anti-inflammatory supplements, and you'll reverse it. High impact aerobics decreases glucose, thereby increasing IGF growth hormone production. Hypoglycemia, same mechanism. Dietary proteins, estradiol, as we talked about. And you destroy the system by using aromatase inhibitors. DHEA can increase production. This is wrong, and not 20%, 15%. DHEA-S, the activated form, sulfonated form, which is the only test we do. We don't do the DHEA because it's the DHEA that protects the heart from ischemic heart disease. Vitamin D directly increases growth and production. Arginine blocks somatostatin. So instead of turning on shutdown mechanism, the negative feedback, you change the threshold so you can produce more growth hormone. And then secretagogues has multi-points of access on the system. These are some of the key systems. Inhibition of growth hormone, somatostatin from the paraventricular nucleus in the hypothalamus, circulating levels of growth hormone and IGF-1, that's negative feedback. Dietary carbohydrates, dietary fats, cortisol, obesity, as we talked about earlier, sedentary lifestyle because physical activity helps. Medication like tamoxifen and anastrozole is already noted. This is the curve of IGF binding protein 3, which has a 20 to 24-hour half-life. It's linearly related to the production of growth hormone at night. The only way we can find out truly how well a person is producing growth hormone at night is to go at midnight and take their blood test, because from 8 at night to 4 in the morning. So when we measured the level in the morning, it's worthless, but you can look at it for some important factors, which I'll talk about when I get through this. So growth hormone levels, they die out rapidly. IGF-1 unbound is rapid, okay? The binding protein 3 is a reflection of how well you produce growth hormone at night. In the morning, we still do growth hormone levels because in my population, head trauma with damage to the paraventricular nucleus leads to uncontrolled production of growth hormone. And when you see high levels of growth hormone in the morning, you have to think medication, tumor of the pituitary, or damage to the hypothalamus. In our blast trauma, our guys with IEDs, it tends to be the hypothalamus. Okay, so 8 o'clock. The principal function of binding protein 3 is to extend the half-life of IGF-1 from 8 minutes to 20 to 24 hours. So the serum level of IGF-1, when you do blood tests in the morning, they're most reliable because they're most consistent for 24 hours half-life. So if it comes out after growth hormone stimulates the liver, it's still elevated. So in the morning when you do an IGF binding protein 3 and it's elevated, you know that they made good amount of growth hormone at night, or they're on something that is stimulating the liver to make binding protein 3, which we'll talk about also. So a single binding protein 3 measurement correlates significantly with the logarithmic of the integrated spontaneous growth hormone secretion. In English, it means high growth hormone production, high binding protein 3 production, and you can follow that faster. Growth hormone's gone in 30 minutes, half-life. Alzheimer's, this is Interesting, what they're now starting to accept or appreciate is the fact that part of the problem in Alzheimer's disease is the fact that damage to the brain because of the level of inflammation that is associated with the process of inflammation that causes what we call Alzheimer's disease, depression, Parkinson's disease, ALS, just a whole group of inflammatory processes that cause depression, bipolar obsessive compulsive, and so forth. That when you have inflammation, what gets damaged is the glucose IGF-1 insulin relationship. They finally acknowledged the fact that IGF-1 is important in the brain to help sugar to get into the neurons. And if you don't have sugar getting into the neurons go through apoptosis. And guess what's produced? Tau protein, fibrils. So you need to have good level of IGF-1 in the brain to help with Alzheimer's disease. So growth hormone from the brain goes to the liver and produces 9 proteins. And IGF-1 is the primary mediator of the effects of growth hormone. And it stimulates body growth and has growth promoting effects in almost every cell in the body, skeletal muscle, cartilage, bone, liver, and so forth. And about 70%, if you believe one author, 70% of the conversion occurs in the liver. The main gland, we'll call it, is the liver. It's a gland. It's not an organ, it's partially a gland. So this is the article. It should have been placed in up above, but shows that IGF-1 infusion of IGF-1 into this mouse model or rat model induced neurogenesis in the progeny of adult neuroprogenital cells. And that's the oligodendrocytic precursor stem cells. And it corresponds to a 78% plus or minus 17% increase in the number of neurons after IGF-1 treatment. So what this tells us is here's documentation in an animal model of improvement in neuron production, the number of neurons. And in training for most of us, we said once you kill a neuron, you can't regenerate it. Not true. IGF-2, as I said earlier, promotes the neurons in gestational, but it also has in adults some important benefits with promotion of granular cell proliferation in menstrual cycle, helps with ovulation, helps with maintaining FSH and LH levels. And in the study from Mount Sinai School of Medicine, found that IGF-2 is linked to memory and could potentially be used to treat Alzheimer's disease. When you use growth hormone, it stimulates the liver and you do get some IGF-2 production. Growth hormone is incredible. It's in 24 distinct areas of the brain and found to have IGF-1 receptors, okay? And in the cerebral spinal fluid, only IGF-2 was found, but no IGF-1. And it's, again, focusing on IGF-2. And then in the anterior pituitary during, is this the one? I can't see part of my slides because something's covering it. I don't know how to get rid of it. Anyway, so the anterior pituitary, which has the executive function, has 100 times more of IGF-2 in the anterior pituitary than any other place in the brain. So let's see if I can move this. Oh, yeah, I can move it. Okay. The binding proteins, BP 1, 2, 3, 4, 5, 6, all have very unique benefits. I have a lecture on it, but I haven't had an opportunity to give it. So I put this slide together so you understand that the cardiologists know that if you're low in binding protein 1, you have an increased risk for cardiovascular disease. Binding protein 2 prevents adipogenesis and improves insulin sensitivity. Binding protein 3, carrier of IGF-1, but has a strong anti-cancer benefit in the nucleus where P53 is. Binding protein 4, anti-colon, because it enhances apoptotic effects. And the only reason why they put anti-colon cancer is because that's the only study they did at the time that I pulled this article. Binding protein 5 helps with bone, and binding protein 6 has neuroprotection and neurogenesis, has those benefits. Another topic that comes up is with telomerase, telomeres. Well, this is a sidebar, which is something I just threw in to let you know that by increasing the level of IGF-1 growth hormone, that it actually increases telomerase production. So it improves the redundant CCCAA, TCC, yeah. So you can get an enhancement in telomerase and extension of it with growth hormone. A recent, this is now going into more of the secretagogue area, I believe. No, it's the GH still. Genentech, who was one of the earlier manufacturers of growth hormone, found over 450 growth hormone actions in 84 different cell types. And again, it's a class 1 cytokine receptor. So here are some of the benefits of growth hormone. I won't go through them because we've talked about the majority of them already. And here are the benefits of the IGF-1, 1/10 insulin-like response, regenerate tau protein microtubules, neuroregeneration, enhanced cognition, and neuroglucose uptake. So in the diagnosis of growth hormone deficiency, let's see, did I miss one slide? The most challenging diagnoses for us to make is because the majority of us do not have full-blown growth hormone deficiency, but we have insufficiency. For us, insufficiency is if you're less than the 50th percentile of the range and still above the absolute deficiency. That's the insufficiency range. And that's where over the past 20 years, we've used secretagogues to help in that range. And that's where why all our patients end up on a secretagogue, because the majority of them are, because of trauma to the head, have a deficiency. So the standard in the United States has been the ITT, which is where you put a patient on IV insulin and drop their blood sugar to the 40s, which stimulates the pituitary system, hypothalamus pituitary, to start producing growth hormone. If it produces growth hormone, then they say it's normal. But that's an artificial system. You don't know where the damage is. So what's been found is that the diagnosis of growth hormone deficiency has relied on measures of GH concentration following stimulation with a non-physiological provocative agent test. Where are we going to get the level of hypoglycemia in our daily life to increase our growth hormone production or not? And this is from Stanford University in Northern California. Due to the pitfalls associated with GH stimulation tests and the lack of reliability and accuracy of the test, what they say is don't do it. And then the study that came out, we recommend that GH stimulation no longer routinely be used for diagnosis of growth hormone. And then the study came out of France where they looked at 6,373 people who were diagnosed with growth hormone deficiency, led to them being on therapy. In this population, they reevaluated them, and 208 young children who were treated with growth hormone didn't need it. And they concluded it was a silly test to do because it changes. It was another test that I didn't have time to put in here where they did back-to-back tests, and they found that one was positive, the other was negative. One was negative, the other was positive. One was positive. Anyway, so the insulin challenge test is not the best way. And what they're recommending is check urinary GH secretion, subnormal levels of IGF-1 in the blood, and clinical assessment. Do they have symptoms or do they have findings that would corroborate with growth hormone deficiency? Growth hormone in cancer. IGF-1 is promitotic anti-apoptotic, which means that it fosters cellular growth replication, and it stops death of the cell. IGF binding protein 3 is apoptotic and anti-mitotic, the exact opposite of IGF-1. So when binding protein 3 binds IGF-1, it now makes it apoptotic, anti-mitotic, because it takes away the IGF-1 that free-floating can, in the nucleus, foster a mutation, okay? P53, these are all the players. P53 is the strongest anti-cancer product in our nucleus. it surveys DNA to find out whether or not there is mutation. If there is mutation, it either tries to fix it or kills the cell through apoptosis. And it turns out that P53 is not working well. Why? It's zinc dependent. Zinc dependent. 1/3 of the world population is zinc deficient, according to studies by WHO and National Institutes of Health and CDC. Also, zinc stops the ability of a group of viruses from replicating because it inhibits replicase that takes over the ribosome to allow the virus to replicate. So all the coronaviruses, influenza A, B, and also H1N1, which is a coronavirus, and enterovirus and rhinovirus. And then the P21, also antimitotic. So when you start looking at this, it's the single most important one, and it triggers cell death. And here's the green is zinc, and P53 abuts to DNA and monitors it for any mutation, aberrancy. And if it's aberrant, it fixes it or kills the cell. And that's apoptosis. So the importance of diminishing IGF-1 is it takes away the ability of anything to foster replication, mitosis. You want to remove that. So one of the genes involved in the induction of P53 was also identified as encoding for binding protein 3. They sit juxtaposed on the same gene. So when P53 is turned on to do its job, it also stimulates more binding protein 3. So the ultimate function of binding protein 3 may be to serve a protective role against the potentially carcinogenic effect of growth hormone and IGF-1, but it's really IGF-1. It's not growth hormone. Growth hormone stimulates IGF-1. And this is, again, the study, Melbourne study. So growth hormone causes the liver to produce both IGF-1 and binding protein 3. So we need to measure that. IGF-1 is promitotic, IGF binding protein 3 is antimitotic, anti-cancer. So the net effect of growth hormone would be a better cancer negating effect and not a pro-cancer effect. So when we use growth hormone, there's a sufficient amount of documentation to show this, to say that no, growth hormone does not foster cancer. It actually builds a system to help you to stop the cancer. Where is binding protein 3 made? In the liver. So if you have a functional liver, it will make it. Alcohol diminishes it. A lot of medications can diminish it. That's why it's imperative that we monitor binding protein 3. So things that will increase IGF binding protein 3 other than growth hormone is hypoxia. We don't want to go and breathe in a bag. Quercetin increases the production of IGF binding protein 3. Retinoic acid does, and so does estradiol. They all upregulate it. So we see women who are on their cycle, they're in the follicular phase or they're in the mid-cycle phase, high estrogen levels, and you see high growth hormone levels. That's what it does. And you see elevation in their P53, in their binding protein 3. Okay, I don't know why estradiol is there. So secretagogues in our body, growth hormone secretagogues, according to this study, can be now found to be synthetic non-natural peptides and peptide molecules that potentiate the ability of the pituitary somatotropes to produce the secretion of growth hormone, and others that can stimulate growth hormone releasing hormone. So they found that they can work both at the hypothalamic level and at the pituitary level. So research centers have identified receptors all throughout the brain, as I talked about in the major areas that have the receptors. And they are, some of them are in our nutrition, the amino acids we take in. And they've been found to possess strong dose-dependent and reproducible GH releasing effects, amino acids, biologicals. Estradiol drives growth hormone secretion via estrogen receptors directly in the hypothalamus and pituitary. So a woman who is peri-postmenopausal with low level of estradiol, onus is on us to get it up so that we can get their natural production of growth hormone produced. So you don't have to, give everybody a growth hormone or a growth hormone secretagogue, as long as you fix all the other hormones. This we've already looked up. This is, in looking at, let's see if this is it. That's the growth hormone with estradiol. Looking at this thing, which is called, this concept called homologous desensitization. In the single channel secretagogues, like ipamorelin or sermorelin or G6P2 or any of those, what happens is they hit the growth hormone releasing hormone. And what happens is that growth hormone releasing hormone burns out the ability of more growth hormone receptors to be made, growth hormone receptors to be made. And a study was done, and they looked at chronic use or long-term use of a single site growth hormone stimulator and found over time that the mRNA for the receptors disappeared. And that's one of the mechanisms that our body uses in negative feedback to control too high of a level of a hormone. So we can use certain other hormones to increase the production of growth hormone. DHEA-S, testosterone, estradiol, progesterone, sleep to increase melatonin or giving melatonin, good protein intake to increase ghrelin, and vitamin D. So the unnatural secretagogues are growth hormone fragments, which is sermorelin, and some of these other products we've seen over the course of our involvement in anti-aging or age management medicine, as well as secretropin. So let's see. So growth hormone releasing hormone is a 44 amino acid peptide, and companies have found that certain segments of the growth hormone releasing hormone, 26 and sermorelin, has the same effect as the 44. And they manufacture it, so it works well. So this is a ghrelin article talking about how well ghrelin works when you stimulate it to increase the growth hormone secretion. So they look at ghrelin as a secretagogue. And what stimulates ghrelin again are amino acids. So people who eat good protein will have a higher level of growth hormone production than people who are vegans. And the vegans that we see, they're very low levels. So we have to put them on things. So this is a warning. The warning is everything I'm going to talk about is research relative to these products that are mentioned. Growth hormone secretagogues reach and advances this drug discovery from Novo Nordisk, and they found that growth hormone secretagogues really work. They work on the pituitary and hypothalamic in dose related to increase the production of growth hormone. And then the GHRP2 peptide, frequently used, is one of those segments of the growth hormone releasing hormone at $530 for 100 milligrams. And what happens is it develops homologous downregulation because you're hitting only one receptor. Hexapeptide, the RP6, the same thing. Hexarelin, same thing. Sermorelin, same thing, 29 amino acids. And what they found actually is that when you use low dose stimulation secretagogue, you get a high peak in the production of growth hormone. But when you use too much, you get negative feedback and it blunts the spike of the growth hormone. So what we use to monitor too much or too little is the growth hormone, IGF-1, and binding protein 3. And the binding protein 3 becomes very important for letting us know how well our secretagogue stimulated growth hormone to have it go to the liver and turn on the production of binding protein 3 and IGF-1. But because binding protein 3 lasts for 24 hours, that's the key marker. That's the key marker. Okay, in using injectable growth hormone, within 48 hours, you'll decrease your production, your inherent intrinsic production of growth hormone by 40%. And eventually, by about 30 days, you will shut down the entire mechanism of your pituitary because it's the hypothalamus making overwhelming amount of somatostatin to shut off growth hormone production. You lose the receptors, you lose the production of somatotropes, shrink because you've given supplement replacement, exogenous GH, which shuts the whole system down. It's a project that we did many years ago to show that this happens. So in using injectable growth hormone, you'll shut things off. So secretropin works on 5 major pathways, okay? This has 5 major pathways. It stimulates ghrelin production. It increases DR2 by its composition. This has mucuna in it, which stimulates the DR2 receptors. It helps to stimulate that synthetic growth hormone releasing hormone receptor through the amino acid composition. It directly stimulates the somatotropes, and it suppresses through arginine the release of somatostatin. So in a normal, all things being equal, here's the threshold of the natural suppression of growth hormone. Once you reach it, the body goes into negative feedback and suppresses the production of growth hormone. So if we can increase the threshold, make it harder for the level of growth hormone to suppress it, changing the threshold, which is what reducing the production of somatostatin, you can get a higher level of growth hormone production and get the benefits. That we already saw. And I was asked to talk about the hybrid protocol that we use in patients who have a medical condition or a fracture or going into surgery. We use a combination program that we call the growth hormone hybrid protocol. And David at University Compounding Pharmacy has the paper that I wrote on it. So growth hormone causes a negative feedback while secretropin provides blockage of the negative feedback mechanism via somatostatin. So what we found in the 2-3 year study that we did is that in using secretropin at night and growth hormone in the morning, we can use less of the expensive injectable growth hormone in the morning because you are no longer shutting off your natural production of growth hormone. Let's say your natural production is 100. And when I use just growth hormone, that 100 goes to 0. So all your growth hormone comes now from the injection. Stop growth hormone. What happens? It can take up to a year for your levels to come back to normal. But if you're using secretagogue that keeps the network, the system between the hypothalamus and the pituitary working, keep it on instead of allowing it to atrophy, what will happen is that 100 will add to whatever you're giving in the injectable. So what happens is you get a higher level with less shutoff and down regulation of your own production. So when you do stop the injectable, you might be using it, a couple of weeks a month, every other month. You want to use the secretagogue throughout on every day, and then add the growth hormone to get a bump up if there's a need for it, surgeries or repair or bone repair. So in closing, the ubiquitous effect of growth hormone, IGF-1, and binding protein 3 mandates that we monitor all of them. And they all have physiological, physical, and psychological effect on our constitution. And longevity fueled by quality of life can only be achieved when growth hormone is optimized. My feeling for the past 25 years that I've been using growth hormone is the key, okay? So the movie with my Green Beret partner, Quiet Explosions, is on Amazon. I just finished another Joe Rogan, number 1589, has a lot of new information that you might want to look at. And I'm just going to run through these slides with University Compounding. They asked me to do this. My relationship with University Compounding has been through 2006. They believed in what I was doing, and the science supports it. The science since 2006 in physician-only hands is all the docs out there do the testing and see that it works. And it consistently works. We have patients who have been on it for over 10 years, and it continues to work, as well as the owner of University Compounding challenged me and went on it. He stopped injectable growth hormone and went on the secretagogue secretropin. So UCP, 12 compounding pharmacist,